It's now my pleasure to introduce Dorothy, who is our next speaker. She has one of the most challenging roles in electrophysiology in running a purely pediatric practice. And she and her team are absolutely amazing. The skill with which they can get the most extraordinary, successful recordings in the most difficult children. Dorothy is the head of the Tony Chris Visual Electrophysiology Unit at Great Ormond Street Children's Hospital, probably one of the most respected and eminent in the world, and she has the same degree of eminence in pediatric electrophysiology. Dorothy.
So my name is Dorothy Thompson, and I'm going to be talking about structure and function in paediatric practice, based upon my experiences at Great Ormond Street Hospital for Children, and with a focus particularly on neuro-ophthalmology. So in paediatric practice, we really need objective tests of visual function. But we need it not only for children, but for others who may not want to, or perhaps are unable to communicate what they can see. And visual electrophysiology offers us an objective test of function, because the eyes, particularly in infancy, the fundus may look okay, but not work. The MRI brain may look okay, but not work. But in contrast, we may have a retina that looks damaged, as in this case, yet works perfectly fine, or an MRI brain may look damaged, but in this case, in holoprosencephaly, this girl had a visual area and could use it well. Now in ICEV, we know that there are 5 clinical test protocols that are described by standards. The middle 3 here that are bracketed are probably suitable for children of 5 years or more who are able to steadily fixate and comply with instructions. So that leaves us with a flash electroretinogram, or ERG, and a visual evoked potential, or VEP. And at Great Ormond Street, or GOSH, we've got an infant protocol so that in 30 minutes, we can acquire information about pattern flash VEPs with a modified skin flash ERG protocol. And these children are alert at the time of testing. We can do that by using handheld flash stimulation and, importantly, biasing the contribution of cones using red light and rods using blue light. And that's instead of having a lengthy dark adaptation period. Last year, we thought that we'd formally look at the diagnostic accuracy of our technique. And I'll just show you here in normal data across the top, plotted for the GOSH protocol in red and the ICEV ERGs in black. Using the dim blue flash, we are able here to show that we've got profound rod system dysfunction in CSMB and in the rod cone dysfunction. Or we've got cone dysfunction correctly identified. But importantly, we also look at the shape of the ERG and we can correctly identify negative ERG waveforms, and the shape matters. And we found overall that there was very high diagnostic accuracy and excellent overall sensitivity. So let's put that to the test. Here we have a 2-year-old girl who was referred to us for regression of developmental skills from 18 months of age. And her attention visually was very variable. She had dribbling and an unstable gait. Now, compared to normal ERG waveforms on the bottom, these are her waveforms, and we can see that she lacks a rod-driven B wave, and also that she has an electronegative ERG here lacking a B wave. Now, an electronegative ERG in this context of progression signposts CLN1, early infantile NCL, or Batten's disease. There are 2, the infantile and the juvenile forms, that are associated with electronegative ERGs. The CLN3, the juvenile type, will often present first to an eye clinic with visual loss due to maculopathy. Now, the retina in these neurological diseases is the progression is unrelenting and leads to blindness. But in addition, those patients with Batten disease have very severe cognitive and motor decline and seizures and premature death. Now, whilst these are rare, the NCLs are the most common of the childhood neurodegenerative disorders. So it all looks pretty bleak, but there is some encouraging report of treatments working in slowing decline, particularly in CLN2, late infantile disease, by directly introducing a human recombinant enzyme into the ventricular system. But this is not changing the progressive retinal degeneration, most probably because of the spectrum of the eye's immune privilege. But there have been some reports recently of some slowed retinal degeneration in the canine model of CLN2. But as yet, we don't know enough about the human disease. There have been attempts across the world to look at the natural history and pool resources. And so there is a disease clinical rating scale that has two domains of motor and language skills. And this has proven to be very successful and have concordance across different centres and different raters. More recently, an ophthalmic severity score, which was based on the appearance of the macula, has been published. And here I've shown some images taken from our cohort of 20 patients with late infantile CLN2. And it shows the grading in this column going from fairly normal to profound atrophic changes at the macula. In doing this work, we also came across patients such as this, where there appears a foveal deposit, which is going to alter the foveal thickness measure when perhaps there's more degeneration than you might think. And then of interest, we also noticed this foveal hyperfundus autofluorescence, which has been reported, of course, in association with achromatopsia. So of these 20 patients, we went on to look a little bit more in detail at the ERG and highlighted the profound cone loss of ERG, which was a lot greater than rod. And this is illustrated in this patient who we saw in 10-month interval. And at this point, we can see that there's a diminution of the rod B wave, but a much greater loss of the cone flicker ERG. So we can conclude that the CLN2 retinopathy functionally is a symmetric cone rod dystrophy. The symmetric aspect is important if we're going to use a fellow eye in treatment as a control. And it has early structural signs of maculopathy. We went on a wee bit further to look at the trajectory of the visual decline. And here we have used individuals linked by lines to see the loss of their ERG, which you can see is precipitous. And we did that by dividing the amplitude of their responses by their lower reference range to give us this index. This allowed us also to combine data from other centres. And overall, classical CLN2 disease shows a rapid visual loss between the ages of 3 and 7 years. We also went on to use the work of Kovacs, who had done a prediction interval for the decline of the centre subfoveal thickness. And we've plotted our data here as these black spots, and they fit it quite well. But of note, it's slightly later before these thicknesses fall below the reference limit published by Lee for central thickness in paediatric patients. We looked also at combining the ERG with the CST, the OCT subfoveal foveal thickness measure directly, and we got good concordance when it was the average DRG. But we show some separation again when we get a bit more specific and look at the cone function, seeing that there's functional loss before thinning. So we have a slight disparity again, where function is preceding structural change. Now, so far, we've looked at the flash ERG, which is summated across the whole retina, but the macular contribution is negligible. But we can, in kids, use the pattern VP as an indirect index of how well the macula in the retina is working. So pattern VP is an index of macular pathway all the way from ganglion cell to the striate cortex. But it gives us this opportunity in certain retinal diseases, such as Usher syndrome ciliopathy seen here, where we have an absent full field ERG, but the OCT is showing this preservation of macular structure, which is sufficient to give us a pattern VP. And this could be a surrogate marker in some retinal diseases of progression or potentially of treatment efficacy. But there is a note here, particularly for neurodegenerative diseases, that the VP is part of the EEG. And if we have a non-seeing child who has no nystagmus with background EEG and seizures, is something that we must consider. So if we have a flash stimulus here, we take in a certain amount of time of EEG afterwards, but it looks very random. We repeat and repeat and repeat until all the random activity cancels out and that time lock to the stimulus appears. And this is the pattern reversal VEP, for example. So as an analogy, these paddle borders are the VEP or visual signal, and we can detect them and the child can detect them if the background wave, EEG, is low. If, however, we have a large background activity or seizure activity, the child will be behaviorally blind because they will not be able to use the signal, nor may we get a pattern of VEP. The second feature of the pattern VEP is its timing, and that develops rapidly in the first 7 months of life, down across this trajectory to 100 milliseconds. These elegant data, plotted by Esther Mikobarata, a colleague from Hungary, have also plotted premature time to peak of the P100. It looks as though the premature babies are delayed, but if there's a correction for gestational age, counting from 40 weeks, they follow the same trajectory. And so the important thing is here is that in uncomplicated labor during maturation, the peak time is normal for age, and also for premature, we count from 40 weeks. So let's put this into practice. We monitor optic pathway gliomas in the ophthalmology clinic using pattern VEPs. Pathway gliomas account for 5% of intracranial tumours in children. And the patient I want to talk about, we saw when she was 5 years of age, but she was diagnosed at 1 because of cafe au lait spots with neurofibromatosis type 1, and her father and brother were similarly affected. Because of visual deterioration, she had an MRI that unfortunately showed a massive chiasmal glioma, and it extended anteriorly and posteriorly, and the neuroradiologist has kindly labelled where the chiasmal extent is here. But there were enhancing components superiorly in the hypothalamus and subthalamic regions. The issue arose because 5 months follow-up with an MRI showed an increased volume of the tumour on one side on the right, but reduction on the left. And we were asked about the functional consequence of this. Now, generally, if vision deteriorates, it's a trigger for treatment. We look for a 2-line difference in visual acuity, but you can see here her follow-up is very similar to her preceding visual acuity. But the pattern VEPs showed a marked prolongation of time to peak. The follow-up is in magenta, the baseline is black, and I've arrowed the increase in time to peak or latency of over 20 milliseconds, very significant. If we look at the structural effect, we can see that there are 2 segments that have just thinned slightly to move into amber by about 5 microns. So we have functional and subtle structural evidence that this tumour is impacting visual pathway function. Now, another thing we look for with pattern VEPs is to detect signs of chronically raised ICP. Now, the gold standard clearly for detecting this is a direct intracranial pressure measurement, ideally overnight with a sleep study. But otherwise, we may look for copper beating of the skull, or we may look for swollen discs. But we know that fundoscopy overall has got low sensitivity. But once we stitch it, it's very specific. Recently, we've got some helpful information from Thompson et al. Because they have looked at OCTs in children who have directly measured ICP. They've come up with 2 values. They have a maximum central anterior projection, seen here in turquoise, and a maximum thickness of the central retinal disc. And these 2 values have a high sensitivity at detecting intracranial hypertension in children, which is wonderful that we sometimes do now have an actual measure, but very hard to achieve OCTs in some of those kids. So for a long time, we have looked for a reducing VEP amplitude over time to forewarn us of a reversible visual pathway compromise with raised ICP. And this can happen before changes in the optic disc or visual acuity. So we know this, but we were very curious to use this opportunity of studying 30 children who had had 48-hour ICP monitoring. And 22 of them had at least 3 serial VEP recordings. And we found that the sensitivity for detecting intracranial hypertension was 70%, whereas the specificity for an isolated VEP was 83%. And the 70% compares it's very, very similar to some colleagues in America who had published some data in a smaller group. So we know that the VEP is a very important adjunct in looking at raised ICP. But I wanted to include this because this was unexpected. These are giant VEP amplitudes. I've plotted amplitude here, and this 76 microvolts, that's the upper limit of the small check ICEV response. And these are data from a 4-year-old girl who had sleep apnea. She was confirmed as having Crouzon's disease, and I've plotted her VEP amplitudes being giant, recovering a little bit, and being giant again. And her ICP measures were high. My reason for including it is to show how when we get giant VEP, is the lag of 3 to 6 months before we get a papillodematous appearance and a change. You see as the hotspot here. So function is preceding structure. And a final case here with pattern VEPs applied in a case of macular schisis in a 4-year-old boy with very poor vision, 0.7 and 0.6. And at time of referral, he had normal looking discs and no pallor. So we were looking for widespread schisis, but the flash ERGs showed a normal B to A wave ratio. Unexpectedly, the flash VEP was really abnormal. So too was the pattern reversal VEP. It should look like magenta control. And so these macular pathway changes were disproportionate to the schitic changes. Went in for an MRI, which showed symmetrical atrophy of the optic nerve, chiasm tracts, but no significant intracranial pathology. But the genetics showed missense mutation in OPA1 and dominant optic atrophy was the diagnosis, with a hearing problem subsequently under investigation. And these schitic changes were actually the microcystic changes that have been associated with optic atrophy. But it was the disconnect between structure and function that helped us distinguish this case. So in conclusion, visual electrophysiology is a powerful and objective functional complement to structural measures, and it can detect dysfunction before structural changes. But we have a lot more work to do to understand the relationship of structure and function in the natural history of some of these rare retinal diseases that are associated with systemic disease. And so finally, just with my thanks to the awesome visual electrophysiology and imaging team at GOSH. Thank you.
Dorothy, thank you very much indeed. Again, the audience seems to be rather reluctant. I wonder if I could ask a question about electrodes. With young babies particularly, and somewhat awkward young children, the choice of an electrode can be slightly awkward. We can try sometimes get DTLs in because they're reasonably well tolerated. Gold foils you don't have a chance with. Sometimes we use surface electrodes on the lids. Of various different types have been tried. I wonder if you'd like to describe your experience of which types of electrode you find most successful.
I think for the infants, the very young children, particularly when they're mobile, it's very nice to have surface electrodes, gel surface electrodes, so self-adhesive ones, and they simply can sit under the eyelid and won't come off that easily unless you've got quite a determined sort of rub. And then for ICVRGs, as in talking about putting yourself in a Ganzfeld and wanting a corneal electrode, we all use a DTL. Similarly, because it doesn't fall out as easily as much, and it can go down to the lower fornix, but there it will sit happily and securely, and we'll get a complete recording, a complete dark adaptation without having to redress or tweak it or alter it in any way. And otherwise, for recordings and electrodes over the scalp, we use standard EEG silver chloride electrodes with a cushion of the salty cream and then a Coban, as in vet wrap, as you might have on horses' fetlocks. It's a stretchy bandage, like a physiotherapy bandage, and that will actually just attach to itself, keep things in place. And so whilst a child is sitting on mum's lap, these have to be reapplied occasionally, but for the most part, we manage to keep everything there and intact. But the key thing about using a surface electrode is actually technically to try and get the cornea down over the electrode, so that we know that the cornea apex gives us the biggest signal. And so if we have a surface electrode on the lower lid, if you like, or the lower cheek, then looking down over it will optimize your response. Because if a child is gazing up or has a strabismus, then we have to account for that direction and also where your reference sight is. So technically there are a lot of dynamic changes that you can make to make a successful recording in kids.
Yeah, very important points. Given the DTL changes in amplitude, probably about 25% between the lower limbus of the cornea and the lower conjunctival sac, would you therefore counsel that in children routinely, you should put the electrode in the sac to guarantee stability of position and trial-to-trial variability reduction, rather than go for the maximum amplitude that you would in an adult by putting it at the lower limbus of the cornea?
That's a really good question. And we do let it go a little lower than actually quite a firm adult, you might say. So we will accept the lower amplitude for the stability. And I think as a sort of technical note, it's easier that way to do and to do that as a first.
I know once when we were doing a multi-center trial using lots of different labs all over the place, this was in adults, not children, but we asked for the electrodes to be placed in the lower conjunctival sac to guarantee that there was going to be less retest variability when the patients came back over the years.
Yes, absolutely.
But sacrificing amplitude for reproducibility.
Yes, I think that's very important. I mean, it's rather like having a surface electrode.
Now, there's a question in chat. Do you ever use chloral hydrate or any other anesthesia in children who are not so cooperative?
No, it would be, sometimes we wish that we could. But we actually work in pairs, and that's the way in which we deal with alert children. So we don't routinely, the reason for it perhaps is that we don't have the resources, because you need this full crash team resources, even if you're going to be using sedation. We also know that chlorohydrates, sometimes they can go hyper with it. It may not have the effect that you like. So you might have more time spent with them running up and down the waiting room before they sort of conk out as such. Now that said, so we work in pairs, we distract and we record, and we work very closely as a team. That said, there are occasions when we can't get close to a patient, and particularly if it becomes a danger to us, if somebody is quite large or they're quite, I suppose, quite able to whack us one or something, and nobody can get to see them. If they're going to have an EUA for their fundus examination, we will go to theatre and we will do the whole 9 yards. So we will, with the anesthesiologist's assistance, we will go for the full dark adaptation. The problem there lies with using the inhalation anesthetics. So like propofol, for example, that's been shown by Welleber's group that it can reduce the B wave by about 50%. And whilst they compare their data to data acquired under anesthesia, so reference data, we don't have that reference data. So if we have a reduced B wave, we think, okay, but we really go to theatre to look for the A wave and photoreceptor function. So that would be our reasoning.
Yeah, my thinking is pretty much the same. And I think the difficulty with anesthetics is that a lot of it, you're working on the assumption that the retina has reasonably normal function to determine what the effect of the anesthesia is. But if you've got a degenerate retina, or you've got conduction problems at a synaptic level, who knows what the anesthetic is going to do there?
Yes, very true. Very true. No, we so rarely, but we rely on this awesome team, as I say, working in pairs. Okay.
I think we've come to the end of the Q&A.
Mm-hmm.